السلام عليكم. محاضرة اليوم بعنوان Abnormal Uterine Bleeding. Disorders of the menstrual cycle are one of the most common reasons for women to attend their general practitioner and subsequently a gynecologist. Although rarely life-threatening, menstrual disorders can cause major social, psychological, and occupational upset. Normal menstrual cycle. Average length 28 days plus minus 7 days. That's to say from day 21 to day 35. From 21 to 35 days. Average duration 4 days from 1 to 7 days. Average amount of blood loss is 35 mol. Average amount of blood loss is 35 mol. Less than 80 mol. Bleeding. Any disturbance, irregularity, duration, and amount of menstrual blood loss. It is the commonest gynecological problem. Abnormal uterine bleeding displays several patterns. Heavy menstrual bleeding, or menorrhagia, is defined as blood loss greater than 80 mol per period. Intermenstrual bleeding replaces metrorrhagia. Breakthrough bleeding, intermenstrual bleeding, bleeding between periods. Menstrual bleeding, bleeding between periods. Menorrhea. There is diminished flow or shortening of menses. Women normally menstruate every 28 days plus minus 7 days. Oligomenorrhea. Cycle with intervals longer than 35 days. Postcoital bleeding. That prompted by vaginal intercourse, often associated with cervical abnormalities. Diagnosis. With abnormal uterine bleeding, the diagnostic goal is exclusion of pregnancy or cancer and identification of the underlying pathology. Menstrual history include age of menarche, date of last menstrual period, birth control method, and the timing and amount of bleeding. Associated symptoms such as fever, fatigue, tissue passage, or pain. Medications, as abnormal bleeding can accompany use of non-steroidal anti-inflammatory drugs, anticoagulants, and agents associated with hyperprolactinemia. Examination. Attempt to identify findings that may suggest an etiology. Moreover, the site of uterine bleeding is confirmed because vaginal, rectal, or urethral bleeding can present similarly. Laboratory evaluation. First, beta human chorionic gonadotrophy. Exclude miscarriage, ectopic pregnancy, high density for mole, may cause life-threatening hemorrhage. Number 2. Hematologic testing. Women with abnormal uterine bleeding, complete blood count, will identify anemia with chronic blood loss. Erythrocyte indices will reflect microcytic hypochromic anemia and show decrease in MCV, MCH, MCHC, and low decrease in MCV, MCH, MCHC, and coagulation screen. Preparation, examination, and cervical cultures. Cervicitis often cause intermenstrual or postcoital spotting. Accordingly, microscopic examination of a saline preparation of cervical secretion or wet preparation can be informative. Cervical cytology or biopsy. Thyroid function test done only if there is history suggestive of thyroid disease. Endometrial biopsy. Sampling and histological evaluation of the endometrium may identify infection or neoplastic lesions such as endometrial hyperplasia or neoplastic lesions such as endometrial hyperplasia is associated with a greater percentage of false negative results with focal pathology such as endometrial polyps and cancer. Rule of endometrial biopsy in heavy menstrual bleeding. An endometrial biopsy or outpatient hysteroscopy is indicated if there is postmenopausal bleeding and endometrial thickness on transvaginal ultrasound more than 4 mm. Heavy menstrual bleeding over 45 years. Heavy menstrual bleeding associated with intermenstrual bleeding. Treatment failure prior to ablative techniques. Sonography. Transvaginal sonography, saline infusion sonography. Here, as we see, this is the uterus and this endometrium, thick endometrium. Here also another picture. This is endometrial polyp, as you see. This is the endometrial cavity. This is the endometrium and this is polyp. As you see, also here there is an endometrial polyp. There is growth. That one appears like that here by hysteroscope. Biology. Number 1, structural. Uterine as leiomyoma, adenomyosis, endometrial polyp. Uterine as leiomyoma, adenomyosis, endometrial polyp. Endometrial hyperplasia or cancer, uterine sarcoma. Cervix, endocervical polyp, dysplasia or cancer. Vagina, cancer, post-operative granulation tissue, fallopian tube cancer, ovary, sex cord stromal tumors. This is structural abnormalities. Number 2, anovulation as immature hypothalamic pituitary axis or aging ovarian follicles, hypothyroidism, hyperprolactinemia, pituitary or hypothalamic disorder, androgen excess as in PCOS, CAH, Cushing syndrome or disease, premature ovarian failure. Implantation, abortion, ectopic pregnancy, gestational trophoblastic disease. Exogenous as intrauterine device, foreign body, trauma. Medications as sex steroid, anticoagulant, hyperprolactinemia inducing medications. Infections as sexual transmitted disease, TB, chronic endometritis, post-abortal or postpartum infection. Systemic abnormalities, coagulopathy, hepatic or chronic renal failure, hyperthyroidism, obesity. Management. In case of acute hemorrhage management, at times women with anovulatory bleeding may have severe heavy menstrual bleeding that require acute intervention. First, admit to hospital, do pelvic examination, sent for investigation, full blood count, coagulopathy screen, biochemistry, intravenous access and resuscitation or transfusion as required, tranexamic acid oral or IV, transvaginal ultrasound, high-dose progesterone to arrest bleeding. Consider suppression with GnRH or ursoprostol acetate in the medium term. Longer term plan, when in diagnosis it has been made. Non-hormonal treatment, antifibrinolytics. Non-hormonal treatment, antifibrinolytics such as tranexamic acid reduce blood loss by up to 50% by inhibiting endometrial fibrinolysis. Prostaglandin synthetase such as non-steroidal anti-inflammatory drugs inhibit endometrial prostaglandin production, leading to a reduction in the menstrual blood loss. Mefenamic acid is the most frequently used agent. Hormonal treatment, combined oral contraceptive pills, it reduces bleeding by around 50%. Levonorgestrel releasing intrauterine system, it reduces menstrual loss by up to 96% after 1 year. Oral progesterones are helpful in the management of women with irregular and ovulatory heavy menstrual bleeding. Norethisternol acetate 5 mg 3 times daily, if prescribed cyclically for 21 days, from day 6 to day 26 of the cycle, is effective treatment for ovulatory heavy menstrual bleeding. Shorter courses of oral progesterone for 14 days are appropriate for women with definitive anovulatory cycles such as PCOS. Injected post-depot progesterone. Injected progesterone are used for contraception and they are commonly used for the treatment of heavy menstrual bleeding. Releasing hormone analog. GnRH analog acts by down-regulating the hypothalamic pituitary ovarian axis and induce ovarian suppression, leading to amenorrhea. Selective progesterone receptor modulators, synthetic steroids that can exert agonist, antagonist, or mixed effect on progesterone receptor and reduce menstrual bleeding. The ulipristal acetate is used in women with heavy menstrual bleeding and fibroids. Now we'll talk about surgical treatments. Polypectomy. Endocervical polyps, it can be avulsed in the outpatient setting. Endometrial polyps can be removed blindly under general anesthesia or by hysteroscope resection either under general anesthesia or in the outpatient setting. Endometrial ablation. Endometrial ablation is the targeted destruction of the endometrium and some of the underlying myometrium. It is suitable for women who have completed their family and in whom all organic and structural causes of heavy menstrual bleeding have been myomectomy, either abdominal, laparoscopic, or hysteroscopic, is the surgical removal of fibroid from the uterine wall with conservation of the uterus. Uterine artery embolization is a well-established technique for treatment of fibroids. Hysterectomy. Hysterectomy should only be considered in the treatment of heavy menstrual bleeding, when a woman should only be considered in the treatment of heavy menstrual bleeding when a woman has completed her family, and when medication and less invasive surgical options have been offered, failure or are inappropriate. There is laparoscopic hysterectomy, abdominal hysterectomy, and vaginal hysterectomy.